Good afternoon, everybody. Amir, Jens, all of Seattle Science Foundation, thank you again for the opportunity. And I'll be talking about the evolution spinopelvic fixation. These are my current disclosures. The only one that potentially is relevant is I'm a consultant for SI Bone, and some of the information in here includes their technology. So we'll hopefully get a better understanding of how we started with this type of spinopelvic fixation, Galveston technique, and have now progressed to something this extreme with 3 screws in each side of the pelvis. Clearly, there's been huge advances. So taking us to the beginning, the traditional indications for pelvic fixation were mainly based on level of instrumentation. So if someone had a quote-unquote long segment posterior instrumentation above L3, that was an indication to add pelvic fixation. Whereas those patients who had short segment fixation, L3 and below, those patients were recommended to stop in the sacrum. And why is this? Well, we know that the patients who have the long segment instrumentation are plagued at the lumbosacral junction by several things. The first is really high rates of L5S non-unions. And the second is risk of sacral fractures, so considered the most distal junctional failure you can have. Bob also brought up the good point that these patients also would risk SI pain, but we'll focus on these 2 for now. So if we look at the literature in terms of union rates at the L5S1 segment for these long segment fusions, studies from 20 to 30 years ago where this was commonly done showed 10 to 25% non-union rates. And really some risk factors in addition to the long instrumented fusions are high pelvic incidence, not having an L5S1 interbody. You can see in that image in the middle there, a very large open disc. That's just a recipe for not healing. If you do interbody, anterior interbody fusions, A-lifts improve fusion rates compared to T-lifts. And those patients who are obese and or have persistently poor postoperative sagittal alignment, not only globally, but also regionally, with persistently high pelvic tilt, are going to have a lot of cantilever forces on those distal screws and are going to compromise your union at the lumbosacral junction. And pelvic fixation does improve union rates. These are studies demonstrating decreases in non-union, so 6.5%, and then a head-to-head study here, S1 only fixation 53%, whereas you add the iliac fixation, it's still high, but it's considerably lower. Now, you don't always need iliac fixation for these long segment fusions. This is a patient of mine, flat back, 2 to 1 stenosis, and for him, we did a L2 to 4 direct lateral, L4 to S1 anterior, and then we perked L2 to S1. And the reason why I thought that this would be reasonable is A, he's got a low pelvic incidence. He has interbody fusion at 5'1". It's an A-lift. Like I said, again, he has an A-lift. He's not obese and reasonably good sagittal alignment. And this ended up being just fine. Now, the challenge, though, with stopping at S1 in addition to non-union rates is there are risks of sacral fractures. And you can see here that as the instrumentation goes above L3, the increased cantilever forces on those S1 screws. And because the pelvis has the worst and most compromised bone in the sacral ala, zone 1, when you put your S1 screws in, that's right at the junction of that corridor. This is actually a case that Sig Bervin shared with me, patient who he took care of. So I'm showing off he didn't do the original operation. He took care of the problem. Anyways, the patient had an L3 to S1 posterior fusion, had a high pelvic incidence, relatively obese, and poor bone quality. Came back with distal pain, decompensation of the sagittal plane. You can see with that red arrow there has a U-type sacral fracture, translation and kyphosis distal to the instrumentation. What Sig did was just extended him down to the pelvis and had some insight to gentle reduction and overall improved the alignment. Patient did just fine. This is a patient that I took care of, fixed outside, also 3-to-1. On the older side, osteoporotic, and ended up having this decompensation not only sagittally but also coronally. And you can see here non-union at 5-1 and bilateral sacral fractures, in addition to fixing the patient flat. So again, poor postoperative alignment set this all up for distal failure. So we ended up doing an asymmetric L5 PSO, and she's still coronally a little bit off to the right, but really the main reason for that is she's a very significant leg length deformity, and that's driving a pelvic obliquity. So the other patient that I think you should be aware of in terms of risks of a distal failure are those with lumbosacral transition anatomy. So this is a good example patient. I'm not proud of this one, but this is how I learned about this being an issue. So this lady, overweight, high pelvic incidence, lumbosacral transition anatomy, and a poor sagittal alignment. So no matter how you draw the pelvic incidence here, either it's from L6 or S1, it's a high pelvic incidence. So what we ended up doing here initially was a ATP at 4.5, 5.6, and stopped at L6. She's still grossly malaligned, and she came to the clinic unable to walk. She had a foot drop, which clearly is abnormal. So we admitted her to the hospital, and it's subtle, but she essentially had a 3-column fracture, chance fracture through the screws because of those cantilever forces. You can see it extends to the posterior. So decompressed she had an epidural hematoma because of the fracture, extended her down to the pelvis, and her foot drop resolved, and she did fine. But again, overall, her alignment's not perfect. But if I were to do this again, I probably would have started to go down to the pelvis in the first place. So that brings me to my current indications for lumbopelvic fixation. So long instrumented fusions. The left picture is a good example of a patient who I think necessitates it. High pelvic incidence patients, those with osteoporosis, like I said, lumbosacral transition anatomy, those patients who are obese. And this is a good example of a patient 4-to-1 that I did, has a very high pelvic incidence, overweight, not great bone, and you can see the fracture of the screw. So in these patients now, even 4-to-1 fusions, I'll be adding at least 1 point of pelvic fixation. So what are pelvic fixation options? So we have traditional iliac screws, we have the S2AI screw, and then you can add in the S1AI. This is something that one of my former colleagues, Dean Chow, and the neurosurgery group at UCSF had published on. Are there differences? I won't run through all the literature because it's relatively robust. Biomechanically, I'd say no, there's no difference between SAI and iliac. Clinical differences, I think you can find studies going both ways. This papers show that there was a clinical difference. Iliac screws had significantly higher odds of revision rates, symptomatic screw prominence, and wound complications compared to S2AIs. You can see here that prominence is clearly different between the S2AIs that are recessed below the PSIS. If you put an iliac screw like this, that's going to be prominent, especially on a thin patient. You have to make sure that this tulip head is recessed below the PSIS to minimize that risk. Now, this study on the flip side showed that there's no clinical differences. The iliac screws really had no increased issues, while the S2AI screws on the flip side led to short-term postoperative pain and increased radiographic loosening at 2 years. So how do you decide bilateral versus unilateral? I will put consistently bilateral iliac fixation if I'm doing, say, a T10 to pelvis or some large deformity correction. For the unilateral screws, I reserve that for MIS or PERC instrumentation. I can show you a couple examples of when I use that. The images don't project great here, but this is a gentleman who had a flat back. We did an L2 to S1 A-lift through a supine paramedian approach, and then we placed L2 to the pelvis. And on this side, we placed unilateral iliac fixation. I skipped the S1 screw to help with rod placement. And this essentially is just to protect against sacral fractures, and number 2, to help that L5S1 segment heal. This is another lady, 75-year-old female, osteoporosis, mild degenerative scoliosis, prior laminectomy, and, we did, again, L2 to S1 A-lift through a supine paramedian approach, and then perked the pelvis with that unilateral fixation technique. And this has worked out really nicely. So bilateral fixation, I'll talk to you about kind of why I like each one, iliac versus S2AI. So my preferred technique is a traditional iliac screws. You can get iliac crest bone graft from it. It doesn't require navigation. And in my opinion, it's more user-friendly, especially when you're placing rods. You use different length lateral connectors. We've seen many examples here today where S2AI screws, you have these funky, wiggly rods that go from S1 down to S2AI. That's because the S2AI start point or the tulip heads are quite a bit more medial. So I prefer the iliac fixation because of that, but it does increase your blood loss. The pelvis bleeds quite a bit, especially in porous cancellous bone. And then the prominence issue is can be real if they're not recessed adequately. Now, I do use the SI screws at certain indications, very elderly patients, where I don't want them to bleed too much. Patients who are very, very thin, cachectic, a lot of times this comes up in cancer patients. You want to minimize the prominence. And then on the flip side, the very obese patients, I tend to do this as well. It's a lot of work to expose a PSIS, getting up and over, and that can bleed a lot. And then if I don't need to harvest iliac crest bone graft, I tend to also use these patients for the cancer patients, like I said. So my initial experience with the single fixation screw in each hemipelvis, the iliac screws, one screw I've removed for pain, and then I've had several with SI joint pain. The S2AI screws, I've experienced almost all screw loosening with them and SI joint pain in all of them. And this is what really made me start thinking about osseointegrative technology for SI quote-unquote fusion or stabilization. We've talked about the options here, and they have been demonstrated to decrease revision rates, whether that decreases SI joint pain. Bob presented a lot of nice data regarding that. But the unilateral fixation, single screw fixation in each hemipelvis is also risk of failure with or without osseointegration. And this is a nice study demonstrating that there can be acute catastrophic failures with this. A lot of times it's those obese patients not well aligned sagittally, and that has brought the field towards doing dual iliac fixation. By placing that additional iliac pelvic fixation, not only does it decrease the SI joint range of motion, as Eastlak discussed, but it also protects the L5-S1 junction a little bit more. It takes the stress off the S1 pedicles, pedicle screws, and then it decreases the L5-S1 range of motion. So there's a lot of different strategies you can use to set up dual iliac fixation. You can do dual iliac screws. You can do dual SAI, so one S1AI, one S2AI, and then you can do a combination of the two. And I somewhat tailor it to the pathology at the lumbosacral junction and what deformity correction I'm interested in achieving. So this is my traditional technique, 2 iliac screws. Again, easier workflow for connecting the midline rod. And if you need to do a kickstand rod and set it up like I did in this lady on the concavity, it kind of opens all the doors for deformity correction, et cetera. Now, the combining iliac screw with an S2AI screw, say you are an S2AI person, if you want to do a kickstand rod, you can't do it with an S2AI screw. You have to do an iliac screw. So the midline rod goes to S2AI and the kickstand rod is off the iliac. This is a good example of that bow type C or OBE2, where you have to correct the lumbosacral fractional curve, and a kickstand rod is usually necessary to correct it. S2AI screws, and then the iliac screw for the kickstand rod. Now, the other indication where I use this combination is with L5 PSOs, and the reason for this is It can create a lot of options for creating multi-rod constructs across the lumbosacral junction. So L5 PSO, you can put that recess rod from L4 to S1. You can then run your midline rod from S2AI, and then you can do your lateral accessory rod. So you get a 6-rod construct across the PSO site distally. And this is an example of a patient where that construct was utilized. You can use the Osseointegrative technology as well for SI fusion. And we recently put out a paper in the European Spine Journal, 7 patients who underwent this technique with good results. Now, the dual sacral-iliac fixation, so one S1AI, one S2AI, these are the ones I use for sacral tumors, pathologic fractures, where I want to keep the instrumentation relatively less prominent and want to get additional fixation in to stabilize across the pathologic territory. And then I also use it in the lumbosacral transition anatomy. So a couple of examples of pathologic sacral fractures. This is a young guy with metastatic renal disease, mechanical instability from that affected sacrum bilaterally. We did an L5-S1 ALIF, and then we perked the back L5 to the pelvis and used the 2 SAI screws, and he got immediate pain relief. A gentleman with multiple myeloma, the entire sacrum, also an isthmic spondy and significant mechanical instability. Did a 4-to-1 ALIF and then perked again 2 bilateral SAI screws, and again, immediate pain relief and able to sit up and walk the next day. This is a patient with the transitional anatomy. You can see here the Bertolotti syndrome. He had a combination of a drop head from a prior post-laminectomy kyphosis. We took care of the C2 down to T10 to correct his cervical spine, cervical thoracic deformity, and then corrected the flat back deformity and connect with the 2 SAI screws distally. Now, dual pelvic fixation and 4 rods are not the panacea. So just because you do this doesn't mean that they're not going to fail. This is a patient that one of my colleagues asked me to help take care of. Multiple prior surgeries, and you can see here distally has failed, broken tulip heads off the iliac screws bilaterally and broken screws. And really the main reason here is the sagittal plane is not well corrected, and he has a persistent non-union through a prior L5 PSO. Has essentially created a spondyloptosis at L5, L4-5. So not a lot of great options to help improve healing here. So what we did is we re-instrumented him, and this metallosis is probably going to give Jens a stroke. But we used these S2AI screws, a crossbar, and then use those to provide additional rods across this non-union site. The question is when this will fail, not if it will. But anyways, there's a lot of different ways that pelvic fixation can help you with stabilizing the lumbosacral junction. So in conclusion, there's been impressive evolution of spinal pelvic fixation. The true purpose of pelvic fixation is to improve fusion at L5-S1, prevent sacral fractures. I just showed that it also has the added benefit of creating multiple rod constructs across the lumbosacral junction. In my opinion, I think pelvic fixation is underutilized, and I think there is a lot of opportunity for teaching to make everybody more aware of the anatomy and how to place the instrumentation. I think that's where our field should go. Current indications for me are listed here. And in single screw, I use unilaterally, like I said, for MIS perk. You can do that bilaterally if you wish. And dual screws bilaterally, long deformities. And I talked about the different ways you can combine them: 2 iliac screws, iliac screw plus an ASAI, or 2 SAIs. And I don't want to this is probably the most important part of this talk, is sagittal alignment restoration and fusion are key. Thank you very much.
Yeah, Alekos, really thoughtful. As always, great graphics and illustrative cases. Can you go back? So I play this all day along today. Can you go back to the slide with the stacked iliac screws, please? So they had a comparison left and right. Yeah, I'm not bypass that fast.
Which one? Which one?
No, go back further. There were two. It was stacked iliac screws. The two examples. Back. And the key point is a simple one. Keep going back. It's a very nice. It's a little bit earlier in the case.
Okay.
Go back a little bit more. I love those coflex spaces, by the way. Why'd you take those out? A little bit back more. No, sorry, then go back the other way. So the point is these transverse connectors. You had a case example left with, keep going forwards, with, so back towards the end, with transverse connectors, keep going forwards. Yeah, the principle there is good, but there's a beautiful case that you had there. Yeah, keep going forwards.
I think it was the last one. This guy?
No. Okay, well, it doesn't matter. Transverse connectors. So these side connectors for pelvic screw fixation.
Oh, yeah.
My anecdotal thought, you had two cases next to one another, one with and one without.
Yeah.
My suspicion or hypothesis is that these side connectors, while sometimes easier to do, yes, thank you, bilateral, are way less stable than others. And the ones that I had to revise are almost always one of those side connectors that basically allows a pivoting to take place. What are your thoughts with your knowledge on that?
Yeah, I can appreciate why it would be a potential site for failure. I have not experienced any failures there. I know people have advocated for having closed heads, so it has a top to it rather than the set screw being the only, and same thing on the iliac screw. I think the failures at the pelvic fixation side are due to poor alignment, persistently poor sagittal alignment. I think if you have the L4 to S1 lordosis nicely dialed in, they're kind of sitting down, and it's not going to have the cantilever, the pull-out forces that are pulling on them every time they stand up, or they're trying to retrovert their pelvis to persistently keep them looking forward. That's my hunch.
So thanks for that answer. And then the second point I want you to address is, so you work for a company that has done revolutionary things in terms of optimizing pelvic fixation, maybe at the cost of too much metal. That's an arguable point. The question I have is, a lot of manufacturers have overlooked the integral importance of the neck of the screw head relative to the shaft. Mm-hmm. They give a great outer diameter screw, very reassuringly large, 10.5, whatever. When you actually measure the neck of these screws, it's 3.5. And this is like a setup for failure. So talk to us about what we as customers, as surgeons, should ask companies to avoid this absolutely clearly predictable failure point. Yeah.
So the pelvic fixation does experience a lot of forces. And as Bob mentioned earlier, smaller diameter screws in the pelvis have higher rates of failure. So minimum 8.5 and upwards, I'd recommend. And that has to be carried out throughout the entire screw. It needs to have robust mechanical properties. So I agree with you.
Right, yeah. So that was one of those hidden little failure points. Final question. So better pelvic fixation, more forces rostrally. You've done some seriously cool studies, and you show a lot of like L2 to pelvis revisions. How long does that L1-2 motion segment survive in your hands with a beautifully restored spine? In mine, it doesn't.
I have been more impressed by the outcomes when it's done minimally invasively. When I open L2 the pelvis, it has not resulted in a good outcome. I've had chance fractures and pretty significant failures through the screws. So if I am going to have I think it also depends on the type of deformity that you're correcting. If it's a very significant sagittal plane correction, I would not recommend stopping at L2 or L1, then going up into the lower thoracic spine or higher is probably important. But the ones that I stopped at L2, those were baby deformities. I wouldn't even consider them deformities. So I think for those, it's reasonable.
Great. No, thanks. In the interest of time, so first of all, thank you, Alekos. And this coming Tuesday, I think you're having interesting case presentations again, and I encourage the audience here and wherever they are in the world to tune in next Tuesday evening. UCSF is always good for a really interesting hour, so thank you, Alekos. Next, we'll have Dr. Roland Kent